You memorize the indications, locate the exact anatomical point, and insert the needle, and absolutely nothing happens. Every practitioner hits this wall. Take a common clinical scenario. An elderly patient comes into your clinic struggling with chronic constipation. The standard classroom solution is straightforward. You select LU-7 or LU-8 because it is the definitive point to force lung qi to descend and stimulate the bowel. However, selecting the right spot is only the first step. The direction you needle determines whether you are building energy or draining it, which determines if the treatment actually fits the patient's underlying pattern. Focusing on the symptom while ignoring this mechanical vector is often why textbook treatments fall short in a real-world clinic. Look at the lung channel. The flow originates in the middle burner, travels to the chest, and runs distally down the arm to the thumb. LU-7 sits here at the wrist. It's a luo-connecting point, creating a direct branch to the large intestine channel, providing the energy required for defecation. Here is the contradiction. Classroom theory states that angling the needle distally, toward the fingers, promotes descending qi, but angling the needle proximally, toward the elbow, also promotes descending qi. If both directions force qi downward, does the specific angle of your needle actually matter? It matters because applying the wrong directional vector can leave the constipation untouched, or in some cases, leave a vulnerable patient weaker than when they arrived. Let's break down the mechanics, starting with distal needling. This means inserting the needle with the natural flow of the channel, angling toward the fingers. This table compares outcomes. Angling with the flow acts as a reinforcing method, adding energy to the system. This is designed for the deficient patient, often elderly individuals with a weak pulse, or patients feeling completely exhausted after straining. Physiologically, these patients lack the baseline energy to move their bowels. Distal needling builds up that weak lung qi over time, giving it the required strength to finally reach the large intestine. You aren't aggressively pushing the qi down, you are nourishing the qi until it has the weight to fall naturally. Proximal needling is completely different. You angle the needle directly against the natural channel flow, pointing toward the elbow and chest. Going against the flow creates a reducing or dispersing method that drains energy. You use this specifically for the excess patient. They have an acute blockage, a strong pulse, or a trapped pathogen like wind, cold, or phlegm obstructing the channel. Proximal needling rapidly clears these physical blockages. It aggressively smashes pathogens out of the way, forcing the stalled qi downward by removing the obstruction. Notice the contrast. The distal approach is gentle and building, while the proximal approach is draining and forceful. Proximal needling forcibly clears an obstruction, while the distal needling provides the motive force for the channel to move itself. The danger in the clinic comes from choosing the correct point, LU-7, but applying a vector that actively fights the patient's baseline health. We can map this out. Imagine applying distal reinforcing needling to an excess pattern. Effectiveness drops to 0. Reinforcing a blockage is like feeding a fire. You strengthen the pathogen, trapping the illness deeper inside. Now look at the reverse. You apply proximal reducing needling to an exhausted elderly patient. The patient already lacks energy. Aggressively draining them further depletes the remaining lung qi, which often turns a temporary difficulty into a chronic, long-term dysfunction. In both of these failure states, LU-7 was technically the correct point to make qi descend. The execution was the problem. Match the needle vector to the patient's energetic deficit, never to the isolated symptom. We can translate these mechanics directly into a step-by-step clinical workflow. This chart starts here. A patient presents with constipation. The first branch is identifying deficiency. Check for chronic exhaustion and a weak pulse. If present, your precise action is distal needling. Angle toward the fingers to reinforce the qi. If instead you identify excess, characterized by an acute onset, physical tightness, and a strong pulse, your action is proximal needling. Angle toward the elbow to reduce the excess and clear the blockage. Internalizing this flowchart is how you transition from memorizing textbook answers to actually diagnosing the human body in front of you. It is entirely true that both distal and proximal needling at LU-7 make qi descend, But the art of the practice is harmonizing the method of that descent with the patient's baseline reality. Stop asking, what point is for this symptom? Start asking, what pattern is causing this symptom? The angle of the needle acts as the final physical expression of the diagnostic insight you've gained into the patient's pattern.